Good afternoon, everyone. Thanks for joining today's session to learn how hospitals have been using the quarterly analyses to stay on top of their key trends, support their decision making, and bring their teams together around the data. Today's webinar will be recorded and we'll share this recording with all of you afterward. And just to help with the recording quality, we've turned off everyone's mics and cameras just to ensure that everything stays a little bit clearer. But that being said, we have set time aside towards the end for a Q&A. So at any point throughout the session, please feel free to drop your questions in the chat and we'll take those up later. If we don't happen to get to your question right away, we'll follow up with you directly afterward. Without further ado, I will pass it on over to Matt.
Great. Thanks, Jamie. Hi, everyone. My name is Matt Gertz. I'm the Director of Innovation here at 3Terra. It's great to see as many people join the call this afternoon as are here. And before I jump into things, I'd actually like to get started with a bit of an announcement. Some of you may know and use our quarterly analyses service. And you probably have seen this on your recent DQA renewal form as quarterly hospital analyses. We're actually going to rebrand this. We're now calling this Focused Insights to better reflect what this offering is and how it's helping hospitals that use it. So what is Focused Insights? Most of you are probably familiar with the annual analyses that we do after the coding year is complete. So after May 31st, it comes and goes, and in June, July, and August, we compile a presentation to every single hospital that we work with. And that presentation does two things. One, it creates a summary of the data quality results that you and the team had using the platform for data quality purposes over the previous fiscal year. And second, and more relevant here, is provides hospitals with insights about key changes that are going on within your hospital. The Focused Insights offering was born out of those analyses and presentations when hospitals told us two things. One, they wanted this sort of information more frequently than once a year. Once a year wasn't enough for people to kind of keep their finger on the pulse of things. And two, they wanted on a wider variety of topics above and beyond the narrow band of things that we had the ability to do over the course of a 45-minute presentation. And so what Focused Insights is an independent analysis of key changes and opportunities at the hospital. And it's tailored to your specific hospital, which I'll get into here in a moment. They're delivered as an executive-ready PDF package on a quarterly basis and presented live to hospital stakeholders. These presentations and analyses cover a wide variety of topics of importance and a growing variety of topics that we've been working with along with the hospitals that are using this currently. So to give you a sense of some of the topics that we address, there's a wide variety of topics that we kind of look at. Some of these that you'll see are obviously funding related. People have questions about weighted cases and QBPs, case mix index. Last month, we worked with a hospital to understand tertiary weight. They want to know, why is our tertiary weight declining? What are the drivers and factors in tertiary? And what data quality opportunities are there as well? Some of these are about clinical efficiency and performance. So we tackle topics like wait times and trends in patient days. Some of these are about outcomes, readmissions, harm, ALC. These are a bunch of the different topics that we end up addressing. And maybe I'll start by kind of tackling one of these as an example. Let's look at pay for results and a P for R analysis. Every hospital that we work with tracks their ED wait times. You already know what your 90th percentile is for the key metrics, your PIA, your length of stay, all those things. You know the trends. But what most hospitals don't know is what is actually required in order to improve our performance metrics. When we break things down, the story is usually surprisingly simple. And in this case, we're doing an analysis that looks at time to physician initial assessment and what would be required to reduce that pay for results number, the 90th percentile time to PIA, by 10 minutes. In this example, and this is pretty indicative of the type of thing that we see when we do this, it's not a widespread failure that we have on an ongoing basis that's causing us to miss this. Each week, there's a small number of patients that are waiting just a little bit too long. And those small delays are what's pushing the performance metric over the edge. So in this example, if we could reduce time to PIA for 4.5 patients every week and reduce it by 5.5 minutes, that would be enough to drive down the PIA by 10 minutes at the 90th percentile. What this means is, improvement isn't about wholesale changes. It's about identifying and fixing a handful of scenarios that are happening on an ongoing basis. And it provides some reassurance, right? Improvement is achievable. Small changes like this can have a big impact. And while that's interesting, obviously that's not enough. Once you know that there's an opportunity in your ED wait times, the next question is obviously, where do we actually focus on this? What should we do? And this is because not all patients impact your metrics equally. What we do is we identify the patient populations that are impacting pay for results the most. So I'll explain this from two perspectives. Again, this is within PIA. The high influence, or sorry, I'll talk about the long stays first. The long stay visits at the bottom of this screen are significantly hurting time to PIA and the pay for results metric. But improvement in those populations would have to be really dramatic in order for it to make any sort of a difference. As you can see, these patients are staying far above and beyond our 7-hour, 30-minute, 90th percentile time to PIA. Some of them are staying 10, 11 hours. It would take a dramatic improvement in order for this to make a difference. The top populations, these high influence populations, are those where a slight improvement in these patients or a slight decline in time to PIA are going to most significantly swing your pay for results number, your 90th percentile time to PIA. And this is because a large proportion of patients in that band are within these particular populations. And so this is where it gets a little bit more actionable. We worked with one hospital who, when we did the analysis, we found that ambulance arrivals were driving time to PIA time for them. And it wasn't because of volume. It was because of how they were prioritizing these patients and problems that were later uncovered in the registration process. So what they did is they implemented changes to how they were handling patients that came in via ambulance. And 6 or 7 months down the line, we looked at it and reran the analysis, and that population is no longer a problem. It's not a major contributor for them. It's improved a great deal. And so from our perspective, that's the difference between knowing what the numbers are and knowing exactly where it is that we should, take action. So having gone through a sample of kind of one of these analyses, let's talk about how an engagement works in practice. We don't just show up with a report like those pay for results reports or a set of reports. We start by asking, what is it that matters to you the most right now? We have a conversation. And for you, maybe it's ALC, and maybe it's readmissions. Maybe it's a specific clinical initiative that the hospital is ongoing. Don't worry if you have absolutely no high priority pressing issues. We have a common blueprint for analyses that we can use as a starting point. We find that certain analyses are more meaningful at different times of the year. We'll tackle financial type topics at the end of the fiscal year. We look at kind of mid-year checkpoints and look at clinical initiatives as well. We can certainly help if guide this along. We also decide what is the audience that makes the most sense for you. At some places, this is a senior leadership team that we present to. Sometimes it's clinical directors. A lot of hospitals that we do this with, it's under a flavor of a quality and utilization committee. Whatever audience makes the most sense for you is what we will ultimately cater this analysis to. Once we figure that out, our analytics team dives into the data and goes deep. They do an independent review of your data. They use the context that we have from working with dozens of other hospitals to identify what stands out within the topics that we're interested in. Before anything is finalized, you see it. So we want to have a conversation so that you can give us feedback. We can refine it. You oftentimes, at least initially, know the audience that we're presenting to better than we do. And we want to make sure that what we present meets the mark with your group. And then ultimately, this culminates into a stakeholder presentation. When we present this, it's not just kind of a one-way walkthrough. It's not just me broadcasting information and throwing facts out at your stakeholders. This turns into a working session where people will throw out questions. We end up having a discussion. Sometimes it's questions for me. Sometimes it's internal discussion about what are we doing in these areas, and ultimately helps to create alignment across the team. What we bring to this above and beyond, the data and the analysis is hundreds of hours in experience presenting to these types of audiences. We understand their expectations. We understand the types of objections and concerns that they're likely to have. We're comfortable enough with this content that there's not a lot that surprises us anymore in terms of the types of questions that we get. And then this cycle repeats on a quarterly basis, and it adapts to priorities as they change. So sometimes, we'll do the first presentation. The hospital will say to us, "Hey, listen, as much as we said we were going to talk about conservable days next quarter, I want you to deep dive on this topic, or I want some more information here." We're flexible to be able to adapt to kind of where the audience needs it and what works best for your hospital. And, I think this is a big part of where the value comes from. Okay. So let's talk about a couple of different examples of analyses that we do. We looked at pay for results. What are some of the other common questions that people are getting value out of? QBPs and funded volumes. Uh, One of the biggest risks that hospitals have is actually pretty simple. You don't want to find out about funding issues at year end. You don't want to have surprises. So what we can do is look at your funded volumes and project where you're headed throughout the course of the year. We could take into account things like past trends at the hospital, seasonality in terms of how many cases we anticipate coming in, and give you a pretty good sense throughout the course of the year where things are going to land at the end of the year. In this example, we're looking at two different QBPs, ischemic strokes on the left and knee replacements on the right. The stroke volumes, as you can see on the left-hand side, are a lot lower than they were the year before. We're a third of the way through the year. We've only done a quarter of the stroke volumes that were allocated. We are not on pace to meet our allocation. Above and beyond that, the other interesting observation is CMI is up a great deal. Last year it was 1.36. This year it's 1.61. This is going to have a pretty significant impact to a future funded rate if it persists throughout the course of the year, given this is a CMI adjusted QBP. On the right-hand side is a bit of a kind of the flip side of the coin. We're looking at knee replacements. We're a third of the way through the year, but we've done 74% of our allocation. We're going to far outpace what we're allocated. And again, this might be an intentional strategy by the hospital. They might be aware of it, but you definitely don't want this as a surprise come, June, July, August. So how hospitals put this sort of thing into practice is one hospital, maybe 5 or 6 months ago, used this analysis to say, where are we through the course of the year and how can we intelligently rebalance our volumes to set appropriate year-end targets and allocations. Another hospital has used this to inform targeted data quality work. So they looked at QBPs where their volumes were low, and they suspected they would be much higher than that. And this comes up on occasion. Our physicians say we've done a lot more than what you say. What we did there is we identified the difference and allowed them to do targeted QBP near miss review, both from a documentation and a coding perspective, and they've recovered those cases that were, misdocumented or miscoded now before May 31st. So it's not going to, cause them any problems. And again, to summarize this, what's the goal? We don't want surprises and we don't want to have missed opportunities. Okay, so weighted cases. This is a pretty common one. And honestly, this is, kind of the analysis that started it all in some respects. We hear this all the time. Why are my weighted cases down? Um, the honest answer is it's rarely just one thing, and usually it's some sort of a nuanced thing to answer. So instead of guessing, we break it down by different perspectives. In this example, and this is again pretty indicative, weighted cases at the hospital down by 8%, even though patient days went up. So right away, there's an incongruency. It tells us it's not about volume. It's not that we had less patients, not that we had less patient days. There's something else, that we need to look at. When we dig deeper, we look at the acuity. We look at the average complexity of the patients, and we can see here that it's been reduced. Okay, so on average, your patients are less complex than they used to be. Part of it is also related to tertiary weight. We had less COVID-19 cases. COVID-19 cases have high weights, they have high complexity, they contribute to tertiary. If these are going to be down, it's going to drag down our weighted cases. And oh, by the way, part of this too is a large increase in ALC, 20% increase ALC, driven, largely due to some, problems in discharging to a couple of long-term care homes. Why hospitals wanted this initially and why they like it now is it allows them to keep their finger on the pulse of weighted cases throughout the course of the year. It helps to provide context in terms of the things that they should be worried about and the things that are outside of their control as it relates to weighted cases. So finally, let me give kind of one more example. Correlation analysis. And here we'll talk about conservable days, but it's just an example. Sometimes the hardest question to answer is like, what's actually driving the metric? It might be about readmissions, it might be about ALC. In this case, it's about conservable days. There are a lot of different factors that could drive conservable days or unnecessary acute length of stay for a given patient population. Our approach to this sort of thing is to do a statistical analysis across a wide variety of factors. We look at patient characteristics, we look at patient care factors, we look at physicians, the day of the week, outcomes. We look at probably dozens and dozens of different factors for each metric that we analyze. And the patterns for this can be pretty eye-opening. In this example, we're looking at pneumonia discharges. And, a precursor to this is, we have a lot of conservable days where our length of stay is unnecessarily high for our pneumonia patients. The things that are driving it are things like diagnostic imaging. Cases with DI, they happen 30% of the time, but when DI occurs, it's a day and a half longer in terms of conservable days than when DI isn't used. When patients have harm, in this case, 10% of all patients have harm, but they end up staying much, much longer than those that don't have harm. An additional 5 conservable days, and this is contributing a fair bit to the conservable days at the hospital. Home care supports. This is kind of a common one as well. When patients go home with supports, it's taking us much longer, and we have far more conservable days than we do for patients that go home without supports. It alludes to a potential problem with coordination of home care supports, and maybe we can start that earlier on in the process. Hospitals have used this sort of thing a number of different ways. And it's, again, about identifying variation and correlation. So, we've identified variation in care between 2 hospital sites. We did this for one multi-site hospital, and we found site 1 had a large amount of readmissions. Site 2 didn't have nearly the amount of readmissions for a comparable patient population, something that, indicated a difference in care path. We've identified variation in care between physicians. We found physicians that were maybe a little bit more reluctant to discharge quickly, or they thought keeping the patient an extra day or two, would be beneficial and it caused readmission rates to be less, and the numbers didn't show that. Um, and so, this is used for a number of different ways to go about things. So with that said, hopefully this gives you a decent sense of the types of analyses that we do through focused insights. Happy to open this up to questions from the group, either from our individual analyses or the approach that we take, or how the engagements work in general. Again, this is about early identification of risks and opportunities. A lot of hospitals come to us and say, we're making decisions, or we hear something anecdotally. We'd like to see it backed by data and backed by evidence, and we help to support that. And these types of engagements have created a lot of, cross-functional alignments between, participants and stakeholders from different realms of the hospital, be it clinical, administrative, financial, or otherwise. So if there are questions, please drop them in the chat. Jamie, be happy to kind of see if there are any questions that I can help to answer before we close off.
Yeah, absolutely. So I did get a question on the side, and I think it's worthwhile bringing it to everyone. For the QBP analysis that you were sharing, what happens if the hospital has in-year real allocations? How do we
Oh, yeah.
handle that?
Yeah, good question. So, obviously, the analysis that we do has to take into account everything that the hospital knows. So, if there is a reallocation, what our team will do is collect that information, update the allocations that we have on file, rerun the analyses, and sometimes it can show a fairly different picture on things. Something that used to be a risk maybe isn't anymore, and it kind of shifts where your focus ends up being. So, we work pretty closely in the engagements to make sure that we have the up-to-date information on the topics that we're supporting the hospital with. And that's kind of one good example of that, where we're kind of working with one hand behind our back if we don't know that you've been reallocated cases.
Awesome. I got two other questions on the side. Everyone's being a little shy today. They're not all getting dropped in the main chat. The one question was about, are we going to be sharing the slide deck? So this session is being recorded. We'll send out the recording to everyone afterwards, so you'll be able to kind of go through the slides that way. And the other question was, overall, can you give a bit of a time frame of how long this process typically takes from start to
Yeah.
finish?
Yeah, I mean, so we start going back to kind of that slide a little bit earlier about, how the engagement works. We start usually at least a month before the first presentation that we do to start to talk about what are the topics and what are the audiences. We want to have at least 2 weeks to have a draft of the analysis in your hand to be able to make any changes, because sometimes what will happen is, hey, when you show that to my chief of staff, they're going to say, what's driving this? I need you to dive one level deeper, peel the onion back just one more layer, so that we're making a valuable use of our time. So we like to start the whole thing at least a month ahead of time, have a draft review in your hands about 2 weeks ahead of time, prior to the presentation with your group.
Amazing. Ooh, couple questions popping up here. Do you work with coded data or interim hospital data?
Yeah, good question. Initially, a lot of the work that we've done is with coded data, and that's more of convenience than anything else. DQA natively has a lot of coded data, and we end up working with a lot of coded data across hospitals. But we are integrating more and more data from EMRs and from other systems. As you probably know, we bring in data from Bourne and CCIS and WTIS, diagnostic imaging in many cases. We do have the ability to look at non-coded data as well, and we're starting to expand in that way at the same time. Great question.
Absolutely. I missed one earlier from Suhair. How do ALC days affect HIG weight and funding? So I'm guessing this is going back to that weighted case analysis.
Yeah, yeah. Wow. Do you want the long or the short answer on that? Um, in HIG weight and funding, how weighted cases work is that it's based on total length of stay. Meaning if for atypical cases, which are where days make a difference, ALC days are treated the exact same as acute days. It will increase the weight, it will increase the funding, but I say that with a very large caveat. For typical discharges, it's a completely different story. So, I mean, remember on that slide where I said it's a very nuanced answer? This is also a very nuanced answer. Happy to have a conversation offline and talk about that in full detail if you're interested.
Great. And I think this one will also um, possibly kick off an offline conversation as well. Is there a way to know when a patient could qualify for two different QBPs? Which one would have a higher benefit? I love that question.
Yeah, yeah. This is actually one that hospitals have asked a fair bit in the past because sometimes you have options, and oftentimes it'll be something like a COPD, CHF, pneumonia type QBP, where documentation maybe is ambiguous, and there's a lot of comorbidities amongst each other. Um, I often turn this to the hospital. I say, look at your data, look at your allocations, look at your funded rates. Ultimately, if it's truly something where you could go one way or the other on a case, that information inside the hospital is most worthwhile. If one of the QBPs you're under allocation and one you're over, that's certainly a consideration. But it's much more nuanced than that as well. I would suggest maybe setting up a quick call after for us to discuss this in detail. Maybe have a specific scenario that you have in mind as well.
Great. It looks like that's all for now. As always, feel free to reach out to us directly.
Yeah, absolutely. And so appreciate your time today. We do unfortunately have limited remaining opportunity to help support these, just like your hospital, if you can believe it. We have resource constraints as well. If you're interested in talking about this, email me directly. Happy to have a conversation about how this might be applicable to your hospital. As Jamie mentioned, we're going to send out this recording. We'll send out a survey link. The survey really helps us to cater these sessions to what you're interested in. So appreciate if you don't mind taking a couple of minutes to fill that out. And as a reminder, we do a random draw for a $50 gift card every time for anyone that's responded through that survey. So please take a couple minutes.